purpose of making sure our data is organized, it's safe, and making sense of it, and to try to help our community. So Ellie, we really thank you and for being on this call as well. First, we're going to start with just some housekeeping so everyone knows how to use GoToWebinar. So if you have any questions, you'll notice on the control panel, there is a questions area where you can type out your questions and we will get to them. We will try to get to all of the questions on this call. We will also send an email summarizing questions after. You could use the chat section to chat with other attendees or to report technical difficulties. There is a phone number there. If you want to take your phone right now and just take a snapshot of that. Also, the handout is in the handout section. If you're having issues during the call, you could just give GoToWebinar a call. You could, like I said, you could download this presentation. And this entire recording this entire webinar will be recorded and will be made available to all of you. So if you miss parts of it, don't worry, you can listen to it again. I will try to speak as slow as I possibly can, as will Ellie. I know we have many non-English, native English speakers on this call. So the goal of this webinar is to present the first analysis. And thanks to all of you who have filled and submitted the FoxG1 patient registry, we actually have, for the first time in human history, the largest group of individuals with data on FoxG1 syndrome. And this is a huge deal for us to finally get real answers and analysis. And also all of this data will be published in a paper, and that will help the entire scientific community. It will excite both biotechnology companies as well as other scientists to look into FoxG1 syndrome, because they will see that we actually have patient data. So we thank all of you for doing this. And if you have not, please do so. So as the next slide, you'll see, Ellie, thank you. I want to first start with thanking two really important parents, Christine Revkin and Bonnie Snoke. Many of you will have received emails from them urging you to complete the FoxG1 registry, to submit your genetic report, any other data you may have been missing. And please know that they are parents just like you, and they have made it their life's mission to make sure that we collect as much information. So when you receive their emails, please don't discard them. Please listen. They are trying to help you and your child. If you have any questions on the registry, if you haven't completed it, you need help, please reach out to them. As well as I have put 4 other parents on the slide in different geographic areas. So if you want a parent in your geographic area to walk you through the registry, please reach out to any of these parents. Their email addresses are on our website. So now we're going to get to the meat of this presentation, and I'll hand it over to Ellie to get started.
Yeah, thank you, Nasha, for that wonderful introduction to the webinar. And I just wanted to echo what Nasha said already, which is that we're just so grateful for all of your participation, because none of this data would be available without all the time that everyone took to kind of create an accurate documentation of your child's progress so far. So really, we're very grateful, and I'm really excited to share with you some of the data that we've put together from basically everyone's hard work at this point. So I wanted to start off just by introducing us to the FoxG1 patient registry. And really the purpose of it is to collect consistent information about children and adults with FoxG1 syndrome at different time points. And so our registry is really in its infancy, but we've already accomplished so much. So we're just about 8 months old now. We haven't even had our registry for a year, and we already have such a huge turnout. So it's been a great success. We've been really motivated to make the registry as available as possible. So it is now available in 5 languages, which is another incredible feat, and very much due to the contribution of parents. So we're grateful for that. We had a lot of input in developing the registry that came from parents, doctors, and genetic counselors. So it's really taken a whole village to get the registry up and running. And another thing that we're really proud of is that we want the registry to be able to give families a voice in how we push forward science around FoxG1 syndrome. Another thing that I wanted to touch on is, why is now so important? Why are we really pushing to have the FoxG1 registry as strong as it can be? And a lot of it has to do with this concept of clinical trial readiness. And this is really just how do we position ourselves to be absolutely ready if a new therapy is developed for FoxG1 syndrome. And to do that, we need to really understand FoxG1 syndrome the best that we can so that we're actually able to prove a new therapy is effective and safe, and also so that we're ready to administer this therapy as soon as it's available, and we don't necessarily need to wait to collect additional clinical data because we've already now understood FoxG1 syndrome. And then there's also a second goal too, which is how can we help FoxG1 children today? And really, the best that we can do is to learn from the community around us. At the end of the day, parents are the ones who know their children the best. And so there's a lot that we can learn from each other, and we're hoping that the registry gives a platform for other families to learn from those around them. So just to give some statistics about the registry, we have 210 individual profiles so far, and there's a really nice split between females and males, so it's quite equal. We're not biased towards one gender or the other. There's an incredible age range within the registry, from 8 months old all the way to 27 years old, which is great. A lot of times in rare disease, information about adult individuals is hard to come by, but very important for developing therapies and for guiding medical management over someone's life. So this is excellent. We're so excited to announce that more than 28 countries are represented in the FoxG1 registry, which is, again, just reflected in the number of profiles that we have. It wouldn't be possible if we were just focusing on a single country. Interestingly, we have 2 sibling profiles, which we're going to think about a little bit more for the publication, but always happy to answer questions for that at the end here. And then really important for us is that 158 caregivers have uploaded a genetic testing report. And I know that this can be so difficult to do, both in terms of accessing the report and then the technical difficulty of getting it uploaded. But we really do need the confirmation of a diagnosis of FoxG1 syndrome to be able to use the data for analysis. So we're really grateful for the families that participated. And if anyone needs more assistance, we're very happy to help you with that. Just to provide a brief overview of FoxG1 syndrome mutations, FoxG1 is what we would call an autosomal dominant disorder, which means that you only need one mutation in order to develop symptoms. And in the vast majority of cases, FoxG1 syndrome is caused by a brand new mutation that is not inherited from either parent. And the medical term for that is de novo. I did bold that here because, as you'll see, I just mentioned there were a couple siblings that were affected, and that's actually due to a pretty rare phenomenon called germline mosaicism or parental mosaicism. And that just is referring to when a mutation is present in some cell types, but not all cells. So maybe doing a blood test maybe doing a genetic test in blood would not identify that mutation, but testing a different tissue could. That is actually thought to be quite rare, but we're learning it's probably a little bit more common in FoxG1 syndrome than we would expect. And the rate of germline mosaicism that we have in the registry is about 5%. So that's something important to keep in mind, and we're going to be discussing that more in the publication. So stay tuned for that. To have a brief introduction back to basic genetics, each gene can basically be thought of as a single instruction, and our body actually reads that instruction as a long string of letters. And the FoxG1 gene is actually pretty small. It has about 3,491 different letters. And then when we talk about a mutation or a variant, we're just referring to a change in that genetic instruction that affects one or more of those letters that make up FoxG1. So these are all the different types of mutations that we had confirmed in the FoxG1 registry. And this information is about a month or 2 out of date because it's when we did the first analysis. So there's a handful more individuals now, but at that time, most individuals who signed up for the registry had a missense or a frameshift variant. And I've put some examples to the side just to show what that notation looks like if you were to look at one of your own genetic testing reports. So in a missense variant, that is when one letter is switched out for another letter. So it's actually quite a small genetic spelling change, but depending on where that variant is located, it might have a pretty significant impact on the FoxG1 instruction itself and how it works. A frameshift variant we would typically think of as having loss of function, and that's because it introduces an early stop sign into the FoxG1 instruction and essentially makes the instruction too short. So there's missing information that could be important. A gene deletion is when the entire FoxG1 instruction is missing. And one thing that's important to note for some of the information that we'll discuss later on is that the gene deletions in our group often include other genes besides FoxG1. So the symptoms that we see might not be just because of FoxG1, it could be because of other genes that are deleted or missing as well. Nonsense variants were also quite common, and this is similar to a frameshift in that it's a genetic change that introduces a new stop sign. And so again, there's going to be information that's missing because the FoxG1 instruction is too short. In a gene duplication, there is an extra copy of the entire sequence of FoxG1. In a complex rearrangement, these are a little tricky, but it basically means that there have been some sort of swaps between genetic information that's more complex than just a deletion or a duplication. And in these cases, FoxG1 is disrupted in some way. We also have a couple in-frame deletions, and these are when there is a deletion of more than one genetic letter, but it doesn't disrupt how the body reads the FoxG1 instruction as a whole. You can basically think of it as just a little piece of the middle of the FoxG1 instruction is missing. So other parts are still there, but some parts are missing. So with our first analysis, we had three main goals. Our first is really to define the clinical spectrum of FoxG1 across a large cohort. It's actually been really exciting. There have been a handful of cohorts published in the literature so far, but in many cases, these are looking back at people who have been published across the years, and we don't necessarily have new information. And so that's what we really wanted to do with this cohort. We also wanted to ask the question about whether someone's mutation or genotype can predict how they do overall. And then we also want to start thinking about what symptoms would we track in a clinical trial? What are important things that we can prove can change with the medication to make it worth doing a clinical trial? And just before we started, I wanted to say a quick note to let you know that in order to identify relationships between genotype or mutation and FoxG1 symptoms, we will be highlighting both the mild and the severe ends of FoxG1 syndrome, which can be pretty tricky to read sometimes, especially as a parent. And so I just want to reiterate that FoxG1 syndrome is really complex and it affects every child differently. And we always want you to remember that your child is unique. They're a combination of both their mom and their dad, and they're so much more than just a data point, which is what we're presenting today. And I know sometimes in these situations it's hard to remember that, but we just kind of want to approach this in the most supportive way that we can, even as we're talking about some things that can be kind of scary. So with that, as I mentioned, our first aim was really to define what is the spectrum of FoxG1 syndrome? What do people look like who are mild or overall? And what do people look like who have a more severe presentation? And so we focused on general health, developmental outcomes, epilepsy and seizures, as well as the movement disorder. And these are some of the core features of FoxG1 syndrome. In terms of general health, we thought about vision. Cortical visual impairment or cortical blindness is when there is a vision impairment, but it's caused by a problem with the brain and the actual structures of the eye themselves are normal. And cortical visual impairment was found in about 41% of people in the FoxG1 registry. We also asked about strabismus or having a cross eye. And so this is essentially when you're looking at the child, do their eyes align correctly? And this can just affect one eye or both eyes. About 65% of people reported having a diagnosis of strabismus. So it does appear that eye health is affected in FoxG1 syndrome. We also asked about whether a mobility device was required to help people move around. And this can really run the gamut. It can include something like a wheelchair, a walker, a gait trainer, or special needs strollers. And 84% of individuals in the FoxG1 syndrome registry reported that they used a mobility device of some type. We asked about feeding. Sometimes a feeding tube, whether it goes through the nose or through the stomach directly, is required to help children eat enough food. And this is especially true if it's unsafe to take food or drink by mouth, which is quite common in children who have lower muscle tone, which we do see in FoxG1 syndrome. And so about 41% of people in the registry reported using a feeding tube at some point. One question that we asked, you might recall from the registry, is what kind of medications were being prescribed for people with FoxG1 syndrome? And we asked this question to help us understand whether there were other symptoms of FoxG1 that are being treated that maybe we didn't ask about specifically in the registry. And so 38 caregivers reported using a medication for constipation or nausea. Both these are quite common, again, in people who have lower muscle tone, so not surprising. 37 caregivers reported using a medication for reflux, again, very common with low muscle tone. And then 26 caregivers also reported needing a medication to help with sleep. And this one is really important for us to think about because sleep can negatively impact quality of life, both for the child and for the caregiver. So we think this could be a really important endpoint for us to track over time and see if it's something that could be improved with a new medication or therapy. Moving on to talk about developmental outcomes, we focused on gross motor outcomes, fine motor outcomes, and language outcomes. So in terms of motor, we found that most people with FoxG1 syndrome were able to roll over. Almost half were able to sit by themselves. About 33% were able to walk with support. And another 18% were able to walk independently without any support. So I think this is pretty encouraging because it shows us that there is a possibility for walking. And I'm sure for any family who's getting a new diagnosis, sometimes it's easy to focus on sort of the scariest aspects of a diagnosis, but this lets us know that it is possible. For fine motor, we asked whether the individual was able to hold an object, and about 73% were. We asked whether someone could use a pincer grasp, and this is just when you're using your forefinger and your thumb to grasp something, and it's a more mature fine motor skill. And about half of people were able to do a pincer grasp. And this is actually quite interesting because FoxG1 syndrome is typically grouped under the umbrella of Rett syndrome, which is really classified by having poor or limited functional hand use. So this is actually showing us that for at least some individuals, there is some hand use that can be used, and maybe we can leverage this in some way. We asked about language, and about 27% used at least one verbal word. And about 28% used a device to help them communicate. One thing that we see all the time in children who have a neurodevelopmental disorder is that they really do understand a lot more than many people give them credit for. And one of the ways to really see that is using another way to communicate, even if they don't have verbal speech. So being able to see that children or individuals with FoxG1 syndrome can use another device, and about 28% of the time is encouraging. And one question that we have, which we'll be answering at a later point in the publication, is whether the people with verbal speech are the same people who use a device or whether they're different. Because if they're different people, then it actually means that almost half of people with FoxG1 syndrome have some degree of expressive language, which is really important to know. So we're going to look into that as well.
Yeah, and Ellie, I'll just chime in here that an AAC device could also be, doesn't necessarily have to be a device. It could also just be, using cards. There's other modulations, and this is an area where diving more into this data can really help us all figure out how can we get all of our children to use more expressive communication, what is working better. So this is definitely a big area for us to focus on.
Yeah, and I actually didn't mention this in the presentation, but it's a good point that Nasha brings up. One of the questions we asked in the registry is what's most important for families to see improvement in, and communication was actually the #1 choice. So this is something that we're thinking about very closely because we know it's really important for overall quality of life, and it also is important for the families of children with FoxG1 syndrome. So our next question that we had talked about is, can we see any differences between the genotypes or the mutation types? And just to point out that for this analysis, to use the statistics, we could really only use groups that had at least 5 people involved. So that's why you're only seeing data here for the deletions, the missense, the nonsense, and the frameshift variants. And that just means that if you have a child in one of those other mutation groups, there weren't at least 5 people that were confirmed. So that's another good push to try and get more of the community to enroll in the registry, just so that we're able to make more comparisons across the able to sit or walk with support based on what type of mutation they had. And so what you'll see here, we're saying is that, for example, for sitting, about 20% of people with a nonsense mutation were able to sit. Or with walking, you can see that about 50% of people with a missense variant were able to walk with support. And one thing that really struck us looking at this is it does appear that people with a missense variant do seem to be more likely to achieve specific developmental milestones. And this was actually statistically significant. So we were kind of able to prove this using different equations or mathematical approaches. And then the other thing that we learned from this is that people who have gene deletions do appear to have more challenges with meeting developmental milestones. And this was also significant. So it kind of gives us the spectrum from people who have a gene deletion where there might be more challenges, all the way up to someone who has a missense variant where there may be fewer challenges. And of course, there are exceptions to the rule. These are just the trends that we're seeing with the data so far. Another question we had is, are there other factors that affect development apart from the mutation type? And so we wanted to see whether having epilepsy or seizures was showing some type of relationship with whether or not a milestone was achieved. And we actually did see that. So we're looking at sitting, walking, using verbal words, and using a pincer grasp across all the individuals in the FoxG1 registry. And the orange bars are showing the percent of people who were able to do that skill who had epilepsy. And the yellow bars are showing the percent of people who were able to do that skill who did not have epilepsy. So there wasn't really a difference in terms of using verbal words, but for sitting, walking, and using a pincer grasp, we actually found a statistically significant difference where people who did not have epilepsy were significantly more likely to achieve that skill when compared to those who did have seizures. It's a little bit hard to say what this means right now. I don't think it necessarily means that seizures cause developmental delay in FoxG1 syndrome, although that's not impossible. But I think it does add another interesting element that we're going to be exploring a little bit further with some more complex statistical approaches. So hopefully we have an update for everyone about what we think this actually means over the next couple of weeks, and it will definitely be in the publication so we can share it with you then. Another question you'll recall us asking in the registry is about changes or differences in behavior. So we saw that about half of children or adults with FoxG1 syndrome reported having a challenging behavior. And interestingly, this was significantly more common in people with missense variants. And we don't really have a reason for this, but one thing we were wondering is if children or adults with missense variants are more mildly affected and do have more functional abilities, maybe this is just reflecting maybe more frustration and not being able to communicate or to be understood the way they would want. So again, no clear answer, but that's one of the hypotheses that we have so far. About 18% of individuals also reported a diagnosis of autism. Autism gets a little bit tricky because many neurodevelopmental disorders do have features of autism, but don't necessarily meet diagnostic criteria for a diagnosis. So it's not entirely clear what this number means, but it does seem that at least a degree of people with FoxG1 syndrome are achieving that diagnosis, which can be helpful for things like services or other things like that.
And even, Ellie, even within autism, there's a spectrum, right? So there's a low functioning autistic spectrum. But yes, typically you have to actually fight to get this diagnosis in order, at least in the United States, and I think in Europe as well, to get more services for your children. And the services aren't always the right services. So I think, like Ellie, you said, this 18%, it could be much higher. It's just also, who are the parents? Are you able to even get this diagnosis?
Yeah, one thing we've been trying to push a little bit more in the rare disease community in general is that one of the reasons people fight for a diagnosis of autism is to get insurance coverage for behavioral therapy.
Yes.
But we're trying to prove that behavioral therapy can be very helpful for people who don't have autism as well. Sometimes we just overemphasize this because it allows people to get the therapies that they need. So this is something that we'll be discussing more in the publication, just to try and make the point that behavioral therapies are probably going to be very helpful, even if someone doesn't necessarily have a diagnosis of autism in FoxG1 syndrome. Okay. So to summarize, based on our data so far, it does appear that individuals with missense variants were more likely to sit, walk with and without support, and use a pincer grasp when we compared them to other mutation types. And so overall, maybe individuals with missense variants have a milder presentation. But again, this is just looking at trends and not single individuals. But it gives us some important information to think about when we're trying to understand how specifically does FoxG1 cause medical symptoms. The other important piece of data that we learned here is that it seems like epilepsy may be correlating with milestone achievement in some way, but we still have a little bit of work to do to really understand what this means. Moving on, the other symptom of FoxG1 syndrome that we wanted to focus on was epilepsy and seizures. And one of the reasons that we want to highlight this symptom is that seizure frequency has been a really common symptom that's been tracked in other clinical trials. So we know that if we took this to a pharmaceutical company or something like the FDA, they would understand what this means and we wouldn't have to reinvent the wheel.
And just so, Ellie, for our non-US participants, the FDA is the, in the United States, it's the organization, the regulatory organization that approves drugs. And so in your country, it will be called something else. But in general, we're talking about any regulatory agency.
So in terms of the definition, a seizure is really just abnormal electrical activity in the brain. Sometimes it has physical symptoms, so you can see it, but other times not, which gets a little bit tricky. In general, seizures have been thought to be very frequent in FoxG1 syndrome, so I was actually quite excited to be able to use this really large cohort to show that maybe it's not as common as we think. So in this group of children who are enrolled in the registry, 61% of people reported a history of seizures, which is quite different than the literature, which has been reporting it closer to 80%. So I think this adds a little bit more information. And this ranged, again, depending on genotype. So individuals with missense variants appeared less likely to have seizures, and individuals with gene deletions appeared more likely. Overall, the age of onset didn't differ between genotypes or mutation types and appeared to be early. So seizure onset was most frequently before 2 years of age. And what was really exciting for us to see is that 30% of people reported that their epilepsy was in remission, meaning that they weren't having active seizures anymore. And so this is actually great news because it shows us that seizure freedom is possible for some people. And again, this did seem dependent on genotype. So people with gene deletions were less likely to report seizure freedom, although some people did, as you see, and people with missense variants were more likely to report seizure freedom. A lot of different seizure types were described by caregivers, which we know is true for FoxG1 syndrome. So people were reporting tonic seizures, which are stiffening, absence, which are staring spells. Clonic seizures is when there's jerking. Myoclonic seizures are very brief jerks. Tonic-clonic seizures are also often called grand mal seizures, and these are when there are both tonic or stiffening and then jerking, often with loss of consciousness. Infantile spasms have also been reported, and this is a specific diagnosis that's based on both the EEG finding and the clinical presentation of the seizure. And then focal seizures were also reported as well. So these are seizures that start in one half of the brain and stay in one half of the brain. One thing we looked at were how frequently were people with FoxG1 syndrome having seizures, both at their worst seizure control and also at best seizure control. And so at worst, in blue, are the percentage of people who were having seizures every day, at least. So this includes people having seizures more than once a day. And you can see that across the board, more than 50% of people were having at least daily seizures at worst control. And so that's quite significant. And also, you know, I don't want to say helpful, but important for us to remember, because it means that maybe this actually could be a useful clinical endpoint to track for something like a drug therapy. But on the flip side, I also wanted to show you that people actually achieved really great seizure control. If we look on the other side, the red bars are showing the percentage of people who had seizures less than once a month. And you can see that the vast majority across all genotypes, for the most part, were having fewer seizures when they were best controlled with medication or some other means. So again, I think this is encouraging because it shows us that many people actually are achieving good seizure control. And so hopefully we can learn from this a little bit more. We asked about epilepsy medication, trying to get to that question I just mentioned about whether we can learn more about the people who are achieving really good seizure control. And a lot of different medications were reported being used, so 29 different seizure medications. When we asked families, what do you think was the most helpful seizure medication? 5 were most frequently endorsed. These were Keppra or levetiracetam, Depakote or Depakine, which also goes by valproate or valproic acid, Onfi, which is a newer medication, which is also clobazam, Klonopin or clonazepam, and Trileptal or oxcarbazepine. One word of caution that I want to take away from this too is just that these are actually really commonly used medications that we know work and have been studied for a long time. So it's not unsurprising that these were the ones families felt were really helpful. And that's not necessarily a bad thing, but it could just be a bias in some way that these are seizure medicines that are commonly used in the population, regardless of whether you have FoxG1 syndrome or not. So I think we have a little bit more work to do here before we really understand this. So in summary, the seizure phenotype for FoxG1 syndrome is incredibly variable, but the majority of individuals report seizure frequency of less than once per month at optimal control, which is great news. No single seizure medication appeared better than others, but encouragingly, no single seizure medication appeared worse either. So this is a question that we're going to continue to look in on. So again, we thank you for your participation because it's a pretty important question.
Yeah, and Ellie, on that, we will send a deeper seizure survey out soon. And the more people that fill this out and the more detail you give will be very helpful. There are other rare disorders that with deeper understanding of seizures have been able to figure out what seizure cocktail works best for their disorder to eliminate seizures. So again, when we send you surveys, please know that the data is really crucial to try to get today to understand what can we do today to really help our kids.
All right, and then the last piece that we wanted to touch on is the movement disorder of FoxG1 syndrome, which has been described, but really only in a few people. So we're really hoping that with all the data in the registry that we can help shed some light on the movement disorder, which could be a significant, could significantly impact quality of life. So just in its basic form, a movement disorder just describes abnormal, increased, or decreased movements that are often involuntary. And in FoxG1 syndrome, a lot of different terms have been used to describe the movement disorder. So things like chorea, which are sort of bigger involuntary movements, dystonia, which is sort of stiffening or contraction of a muscle that is not necessarily permanent, it can be intermittent. And then facial dyskinesias are just movement disorders that can affect the face as well. And these are all things that are commonly described in FoxG1 syndrome. In our registry, about 58% of caregivers reported a diagnosis of a movement disorder. But one thing that I actually think is really important is that about 20% of people didn't know. I'm going to touch on that a little bit later. But in general, of the people who reported use of a medication for a movement disorder, these were the 5 that were most commonly used. And they're baclofen, tetrabenazine, clonazepam, trihexyphenidyl, and clonidine. One thing that I wanted to point out here, just as we're continuing to improve and update the registry survey, is that not many people actually gave us information about medications, both for seizures and the movement disorder. And this is an area that we're really interested in learning more about, because to Nasha's point, we're hopeful that it can help people today and not just in the future. So this would actually be a great area to get more caregiver response in the future, just as we're trying to answer these important questions. So to summarize the little that we know about the movement disorder so far, it actually seems like it might be underreported in people with FoxG1 syndrome. And maybe there's not great education for caregivers about whether or not their child has a diagnosis and whether there's something we can do about it. So to me, this feels like a missed opportunity, and it makes me wonder if some children could be better, could have an intervention that would help them with their movement disorder and help them feel more comfortable. And so this is something that we're going to pose in the publication, and I hope this can create some more dialogue with different physicians or therapists that you're seeing, to make sure that if there's anything we can do to make children more comfortable, that option is being presented.
And just so I do see the questions are coming in. Thank you very much. Please know that we will get to questions soon and answer them all. So just please keep typing in your questions in the questions area of your control panel. Thank you.
Yeah, we're wrapping up, so don't worry, there'll be lots of time for questions.
Yeah.
So the last point that I wanted to talk about is a little bit technical, but it gets back to this point about thinking about clinical endpoints. When we ask caregivers where they would like to see improvements most, as I mentioned, communication was prioritized. And when we think about a clinical endpoint, it needs to be something that represents a direct clinical benefit. So for an example, if we chose a hiccup as our clinical endpoint, that wouldn't actually be very meaningful, because whether you treat a hiccup or not doesn't say very much about FoxG1 syndrome. So we're really looking for things that tell us overall, how is someone doing with FoxG1 syndrome, and can we prove that we're improving things overall? And the other super important thing is that a clinical endpoint needs to be sensitive. So when we're doing drug trials, these are not things that go on for years and years and years. They're things that happen in relatively short time frames. So the clinical endpoints that we choose need to be able to demonstrate change on the order of 2 to 3 months. So these are all things that we're keeping in mind, and why the registry data is so important, because we get to hear from you what are the symptoms that we think will fit these criteria, which are actually pretty hard criteria to meet. So learning from all the data that we've been able to gather from families, we've come up with a few clinical endpoints that we want to explore further. So seizure frequency, definitely, because it seems that at times people have frequent seizures, but also because seizure frequency has been used in other clinical trials successfully. We also want to think about movement disorder severity, because this is something that can be scored remotely. You don't necessarily need to go see your doctor to have this scored, and we hope we can demonstrate change pretty quickly. Visual acuity, remember when we talked about there being relatively common diagnoses of cortical visual impairment or strabismus? And visual acuity is also being considered as an endpoint for CDKL5 deficiency disorder, which is kind of lumped under the Rett syndrome as well. So we want to think about that carefully if it's been successful. Developmental outcomes have been used successfully. One of the best examples of this is for Spinraza, for spinal muscular atrophy. The endpoint that was used for there was actually being able to sit independently. So if we can demonstrate good natural history data for that for FoxG1 syndrome, it's a good candidate to think of. And then another one, which I mentioned previously, is sleeping, which we know has a pretty significant impact on quality of life overall. So it's another feature that we'd like to track. So moving forward, what are our next steps for clinical trial readiness? Nasha mentioned this already, but to raise awareness about all the work that we've done for the registry and all the work that you guys have done, we're going to be summarizing all of this information that we talked about in much more detail using a medical publication. And once that's available, of course, we will make it available to the community as well. And we'll probably host another Q&A at that point to make sure we're answering everyone's questions. We're trying to work on a pretty tight timeline to get this completed before the end of the year. And as I mentioned, our priority is to share this with the community who really helped make this data possible. One important piece that I wanted to bring up, and Nasha has already touched on this as well, is that to really understand FoxG1 syndrome, we need to know what it looks like over time. Right now, the data we have is so helpful, but it's just a snapshot and it's not a true representation of your children. And so we're going to start thinking about ways that we can collect information at more than one time point so we can see how things change. One of the ways that we'll be doing this is releasing an update for the registration survey. So again, your participation is so important for that, and we're really grateful. And then, like Nasha also mentioned, we're going to be releasing a couple more targeted surveys over the next little while to help tease out some of the interesting questions that we've come up with after looking at the data for the first time. And as always, there's really strength in numbers. So your participation is critical, and getting the word out is also critical.
Yeah, and to that, you may think, oh, I'm just one person, I don't do it, it's fine. It just doesn't work that way. We are such a small, rare disease. We have about 630 children around the world that we have found. So every person who fills in the registry is greatly helping us understand this disorder. And as Ellie said, it only works if you continue to fill out the registry. So every year we will send an update. And it should not take more than 10 minutes, and we will also send other surveys. And again, every survey should really not take more than 10 minutes. So giving that much of your time will help us as a community, and it will help benefit your own child. So really, we hope you take it seriously.
I think this is my last slide, but this is just to point out some of the things that we're thinking about now in order to get us ready. And I've touched on most of these already, but just really understanding how are symptoms variable? Why and how do they look different in different people? What are the symptoms that change over time? So there's been some early reports that the movement disorder changes over time, where in early stages it appears that there are extra movements, and in later stages there are fewer movements. So those are important things for us to really establish. Again, we want to consider what are things or symptoms that other groups have successfully used in clinical therapies, and are there existing ways to measure these symptoms? One of our goals at FoxG1 research in general is really to accelerate drug discovery for FoxG1 syndrome and not reinvent the wheel. So we want to make sure that what we're doing it effectively, but also efficiently and as fast as we can. So this is one question that I actually have for the group. As we're thinking about releasing the update, what are things that we missed the first time around that you would really like to learn from other caregivers of children or adults with FoxG1 syndrome? So feel free to post them either through this GoToWebinar or to send us an email separately. But these are the things that we want to think about. What are things that are important to you guys?
Absolutely. And before we get into research, I'm going to go through some of the questions that have been asked on what Ellie has gone through. So I've got a question from Monica asking, you know, her child has a mutation, a C460 DUP-G. And she is thinking that it's a frame shift, but she's not sure. And frankly, there's many of us that, you know, are not sure what kind of mutation our children have. Not everyone is lucky to have Ellie as a genetic counselor. So Ellie, could you help Monica answer that?
Yeah. So the C460 DUP mutation is actually one of the most common mutations found in FoxG1 syndrome, and it is a frame shift mutation.
It is a frame shift. And on that, we are actually about to launch a study on that specific mutation, which I will talk about next. I've got a question from Judith. FoxG1 was diagnosed for us on the epilepsy panel for many of us because she, you know, your child had a type of seizures, febrile seizures. So we are missing, are we missing diagnosing people because they've never had a seizure? That's a great question.
It's such a good question. So I would say, I think we're not necessarily missing as many people as we might. A lot of the people in the registry were actually diagnosed using an exome test, which is used for people who have seizures and also for people who don't have seizures. But I think it's a really important point that some diagnoses are probably being missed in children who don't have seizures. And it's one of the things that we're going to emphasize in the publication. We actually have a specific paragraph that's basically, you know, when should you try to diagnose someone with FoxG1 syndrome? Because you're right, I don't think it's as obvious in children who don't have seizures.
And I do know it is on a few other panels, like the microcephaly panel, for example. Yeah. So it's on a few other panels as well, but definitely it's a great question. Okay, let me go to our next question from, okay, this is great. We have a question on challenging behavior. So we did talk a little bit about children who have behaviors. Ellie mentioned it's we're just seeing it more common in children with missense mutations. The question is, does ADHD, is that a type of challenging behavior?
It's a great question. I would probably consider it separately because it's a unique diagnosis. And it's this is sort of a great example of the types of updates that we want to make to the registry just so that we can be more specific. In general, for challenging behaviors, we're thinking about things like either injurious behaviors to self or to others, tantrums or crying, just things that are a little bit more difficult to manage, but probably outside of ADHD or a separate diagnosis, at least in this context.
We've got a question from Yuki on duplication types. So Ellie, maybe we want to go back to that slide that talked about the different types of mutations, and then Ellie can talk about why in the data she showed, we didn't include duplication.
Sorry, I'm trying to find here. So why we didn't include duplication in the analysis?
Yeah.
Yeah, so the type of statistical analysis that we were doing, we decided to exclude groups that had fewer than 5 individuals. And the reason for that is we wanted to make sure that we were able to detect statistically significant changes, which is just much harder to do with smaller numbers. And in the case of having 2 individuals, it would actually be inaccurate to do that. So again, that would be the reason why some genotype groups were missing. But it's not that we don't want to do those types of analyses. So if we can get more numbers for those individual groups, that would be fantastic.
Absolutely. And duplications are really important for the entire community to better understand. We have another duplication question. So for the 4 children with the duplication, did they have, Michael's asking, BNS attacks, which is called West syndrome, so infantile spasms. Ellie, do you want to talk a little bit about that?
Yeah, so it's actually a great question. There's been some good work in the literature already showing that children with FoxG1 duplications do appear more likely to have infantile spasms or West syndrome. In our group, I can't recall off the top of my head what the seizure types were, but we do talk about that in the publication, and I can get that answer to you after. I'm just sorry I don't have it right now.
We have a question around, there's a parent asking if their child is on the registry. So you have to go and sign up for the registry and put your child on it. If you're wondering if you did it and if it worked, you could email, and we'll put this in the chat as well, either Christine or Bonnie, and their emails are simply Christine@foxg1research.org or Bonnie@foxg1research.org, and they can help guide you and answer that question. Our next question is from Angela. Her son will be 25 in April, and she'd like to know who is the oldest child with FoxG1.
So I don't know who the oldest
child.
Yeah, the oldest person.
Yes.
I don't know who the oldest person in the world is. There's probably someone much older out there, but at least in our registry, the oldest person that we have is 27 years.
We have a question on cannabis oil, which is a great question, CBD oil. Do we have information about the response of that on children's seizures?
We do, in the sense that we ask, we included cannabis or cannabidiol as one of the epilepsy medications that we inquired about. And so we have information in that we ask people what were helpful medications or helpful items that they use to treat seizures. And I know that a couple of people said CBD was helpful, but it was not enough people to make it into the top 5 recommended or top 5 endorsed medications.
And that could be because it's a newer, there's more people now trying it. So
I think CBD is hard too, because even within people who have the same condition, it's been shown that there are people who respond well and people who don't respond well at all. So I don't think there's necessarily reason to believe that that would be different for FoxG1 syndrome. It will probably work for some people and might not be tolerated in other people.
We have a question on movement disorders. So from Marie, do they tend to improve over time?
It's a really good question, and it's actually one that we don't know. So it's part of why we're starting to think about how can we think about things at multiple time points and not just one time point. In the literature, there is one very small study looking at, I believe, 3 people and their movement disorder over time. And so it's not so much that it got better in those 3 people, but it changed. So instead of having more hyperkinetic or extra movements when they were younger, they started having more dystonia or more stiffening and fewer movements. And so that's sort of the information that we have now, but it was only based on 3 people, and we don't have much information about whether their dystonia responded well to medication. So these are all things that we really want to highlight in the publication, because things like dystonia can be treated, and we want them to be treated if they're making someone uncomfortable.
And we'll know also as parents fill out the next line, so we'll know if those children who had movement disorder after a year, did they get better, and so on. So that will also help a lot. And on the movement disorder, and this is something Ellie touched upon earlier, is there's a question on how do I know if my child has a movement disorder? And that's something that we did see people struggle with.
Yeah, I'm actually really happy you just said that, because one of the things that I was hoping we could see from having done a webinar like this is, can you take this information back to your doctors and say, hey, 60% of people with FoxG1 syndrome have a movement disorder, but, I don't know if my child does. Can you tell me if they have a movement disorder? Just to sort of advocate a little bit for being educated about these types of things, which might be important for us to know, especially as we're thinking about it as a possible endpoint.
Exactly. We have a question around word disorders or the absence of corpus callosum noted.
So that's an excellent question. And this is just referring to some of the findings that we know are more common on brain imaging for FoxG1 syndrome. And so because this registry is designed to be based on caregiver reports, we don't have a lot of questions about things like brain imaging or specific EEG findings, just because those things can be a little bit tricky to remember for a lot of people, myself included. So we're starting to think about other ways that we can characterize things like a corpus callosum abnormality in FoxG1 syndrome in different ways. The other point that I would make too is the real focus of our group right now is to identify things that will accelerate drug discovery and drug use for FoxG1 syndrome, and not just drug therapy, but gene therapies and other things that are being considered for many different disorders. And so one thing that we've thought a lot about for the brain imaging findings is whether those are things that we could actually show change over time. And the other challenging piece is that MRIs are just really expensive. So is that the right endpoint for us to choose if it's something that's going to be hard to track as well? So it wasn't like a priority for us in the first round of the registry, but we are expanding and thinking about how can we track those types of symptoms in addition to these main ones that we want to focus on.
Exactly. We have a question around constipation, which is a huge issue. And this parent is saying that she's being pointed in the direction of a cecostomy. I hope I said that right, cecostomy. But she's wondering if the doctors have looked at a pacemaker or a vagal nerve stimulators instead of an invasive procedures. Do we know anything about that?
I don't. I'm sorry.
That's a tough one. That is more for your actual doctor, I think.
I didn't see anything like that reported in the registry. So I can at least say that I didn't see it in the registry, but apart from that, I don't know. I'm sorry.
Okay. Okay, we have a lot of questions coming in. I'm going to do my best to get to all of these. Okay, sorry, I've just lost where I was. Okay, so we have got a question from Vivian that says seizures. You said that seizures start until 25 months, but which is I think what you're saying is what is a late age seizure?
So like what is the latest age that someone had a seizure start?
Yeah.
I don't remember off the top of my head, but that's a really good question. So I'll go and look and see what we can find. One limitation of the way that we have the registry survey set right now is that we would only know if it happened more than 25 months of age. We wouldn't have a specific age. So I do know that people started to have seizures after 2. It's just that the majority of people started seizures before the age of 2. So hopefully with maybe one of the updates that comes out about seizure history, we'll have a better sense of what was the oldest age that someone had a seizure for the first time.
Yeah, that's a great question. We've got a question around sleep, which is something many of us deal with. Are there medications that have seemed to work better than others? Ellie, did we ask anything about sleep medications?
So not specifically. It was more that if a parent reported using something like melatonin, then I knew that that was for sleep. So we don't have any data right now about things that were useful. One thing that I would say is that sleep for FoxG1 syndrome will probably be managed very similar to other neurodevelopmental disorders. But what does get tricky is that sometimes people are afraid to use things in a rare disorder if they don't know how it will work. So that's one thing that we're hoping we can accomplish with the registry, is to be able to show that, just because someone has FoxG1 syndrome doesn't mean that you can't use recommended medications.
And we will send out a sleep survey soon as well to get more details into that. We have a parent that said for her own child that ferrous sulfate has been very helpful in terms of sleep. And so she suggested checking those levels with your doctor. So thank you for that. Let's see. Okay, this is interesting. We've got a question around, she said, around regression So I think it says, is there a registry about kids that regress their progress, movement, or communication? So have we seen any regression? I think, again, we'll know that more as we continue the registry and folks are entering data year after year. But Ellie, if you want to talk to that a little bit.
Yeah, I actually didn't put it in the presentation, but we did have a lot of caregivers report that their child experienced at least one episode of regression. One thing that gets a little bit tricky for us in knowing how to interpret that data is, regression can mean different things to different people. So it's one of the things that we want to expand upon in the updated registry, is to really actually understand what do you mean when you say that they had a regression, so that we can better educate our community. Because I actually think it will be really important, because when you look at sort of the traditional diagnostic criteria for FoxG1 syndrome, it's there should be an absence of a regression. So it would be really important for us to better characterize that.
We've got a question around a type of mutation someone's child has. It's a C.757A is greater than G, and she'd like to know, she or he would like to know what type of mutation that is.
So I don't know off the top of my head, but I'll write it down. You said 757A to G?
Yes, and I also have another one, a C537, C is greater than A.
So what those notations are meaning is they're giving you specific coordinates of a change. So in the example of the first case, 757A to G is meaning that at the 757th letter of the FoxG1 instruction, where we would expect to see an A, there's actually a letter G. And for the second example, for 537, that's saying that at the 537th letter, where we expect to see a letter C, we actually see a letter A. So what I can't tell from that right now is what the actual impact is on the FoxG1 protein, but it's pretty easy for me to look that up, so I can do that.
Okay, I do have some questions around our gene therapy and other things, which we will get to next. So I'm going to save those questions. Okay, let me see. So we've got lots of questions. Are FoxG1 children good candidates for gene therapy? Again, we'll get into that when we talk about the therapy. Okay, this is from Kirk. Is there data, or will there be data, on what medications have proven efficacy on treating seizures, movement disorders, and related diagnoses, so we can ask for them from our Fox's medical teams?
Yeah, so it's mostly going to be limited to what I've shown you already, which were for seizure and movement disorder, what were the 5 medications that people thought worked the best most commonly? So that will be included in the publication, but we won't have sort of data beyond that, with the exception that I will say, when we've asked about medications that were not effective, nothing has really consistently come from that. So it doesn't seem like there are things that are overwhelmingly not effective.
Exactly. We've got a question from Marie. Do children with FoxG1 syndrome have sensory hypersensitivity?
It's a great question. We see sensory processing disorders fairly commonly in neurodevelopmental disorders, so it's certainly possible, but it's not something that came up frequently in the registry.
Yes, and we can also advance the registry with these questions you guys are asking, so thank you so much. I've got a question on how many families are there with one or more parent that is a carrier?
Ooh, good question. So we know that there were 2 sibling pairs, so it means that probably at least one parent carried a mutation somewhere, but they were not likely to be traditional carriers in the sense that you would think if you went and got carrier testing as part of your prenatal care. And this kind of goes back to that tricky concept of mosaicism. We know that if you have a FoxG1 mutation in every cell of your body, that you will have symptoms. But what we're learning is that there's probably a threshold. So for example, if you only have a FoxG1 mutation in the sperm or the egg cells, you probably won't have any symptoms of that because FoxG1 primarily works in the brain. And there's probably lower levels of mosaicism, like maybe if you only have 3% mutation or something like that, but it's not really something that we've been able to prove yet.
We've got a question. Someone is asking, my daughter has, I'm sorry, I've just lost it. My daughter has a growth hormone treatment because she has not grown in 3 years, breaking her size curve. Do other FoxG1 children have growth hormone deficiency or IGF-1?
That's a great question that we haven't been able to get from the registry specifically, but we do know that growth is one of the main domains that's affected with FoxG1 syndrome in terms of head size, weight, and height. So it's certainly a symptom that we see. Whether or not people are treating it with things like growth hormone, we didn't ask that in the registry.
And that's a great question for us to include in the update, so thank you. We've got a question about someone asking about her son, why his seizures are not showing up in the EEG. Would you be able to answer that, Ellie?
It's hard. We know that happens sometimes. But yeah, I'm sorry, I don't really know how to answer that question apart from saying that it does happen and it's very frustrating, and so I'm sorry.
I've heard it's because, sometimes it's just too deep in the brain, but again, it's not a great answer. We've got a question from Scott. Among patients who are more mild, whether missense mutations or otherwise, what are the best case scenarios? In other words, what are the capabilities of patients with milder outcomes? And do we have any information around early developmental milestones that represent commonalities across these patients?
It's a great question. So we're going to highlight 3 different people in the publication. All 3 people had missense variants, and they were remarkably mildly affected. So all achieved all of their milestones a little bit late, but not completely, not to a significant degree. All had verbal speech, and many were just significantly more functional than what's been classically described for FoxG1 syndrome. And so we wanted to highlight that in the paper, that there is, some pretty impressive variability that we've learned of from this registry.
Okay, I'm going to answer maybe 1 or 2 more, and then we'll come back to questions. There's a question on sleep, which I think we went to, that we are going to send a sleep survey to get more information there. Okay, so we've got a question around, again, to follow up on missense, that we see them as milder. Are we to understand from the data that deletions are the severe end of the spectrum? Does the size of the deletion affect its presentation drastically?
It's a great question. One of our limitations right now is that we didn't get the deletion size from everyone. So depending on the type of documentation that was uploaded to the registry, sort of proving the presence of a deletion was different between different families. So I would say that one of our hypotheses for why the deletion genotype appears to be more severe is that many of these cases had other genes included in the deletion. So whether their full presentation is due to FoxG1 syndrome is not clearly established, and probably a little bit unlikely, especially in some cases where there were, like 50+ genes included in the deletion. So it's an excellent question. I don't think we have the numbers to prove it, but I would say that your line of thinking is consistent with ours.
Yes, and we are, in addition to additional surveys, we will be announcing more detailed studies that we are going to be doing to get better answers around these specific questions as well. So we're going to move on to the research, and I will answer several of the questions I've seen during that. Ellie, if you could go to the next screen. So this is what we call our path to a cure. And the most important thing when we started the FoxG1 Research Foundation was to think of what is the strategy that is going to get us to clinical trials and to a therapy in the fastest and shortest route possible. we're lucky that there are already other disorders, rare disorders, neurological disorders that are seeing drugs that have helped their children. A great example Ellie brought up earlier was Spinraza for SMA, which is an extremely severe neurological disorder. No one thought a cure was possible, and we are actually seeing a drug that's in the market that's working and reversing symptoms. So we do know it's possible, and we've learned from these other groups, and we've learned from biotech companies and pharmaceutical companies, and we've developed our path to a cure based on their advice. And we're very much guided by our scientific advisory committee. So what we are doing is, number one, we are building FoxG1 models. And what that means is animal models. So that's mouse models, zebrafish models, as well as human models. And the way we do that is, many of you have submitted blood samples and skin samples to our biobank. We thank you, and we hope more of you continue to do so. If you take a skin sample, what we've done is gone back to its stem, its original state, and it's called an induced pluripotent stem cell. They're also referred to as IPS lines. And that's going down to its stem. And once you get to a stem of a cell, you can then convert it into anything you want. So we are converting these stems into brain cells. So then we can literally go in and learn, which is step 2, study these models and understand. We can slice into that brain cell and understand at a cellular level, a biological level, how is FoxG1 affecting the brain? How is FoxG1 in our mouse models affecting other organs, other parts of the body? What are other genes that are affected? What are the pathways they're called? So this is all the work that we are currently doing. We are also in step 3 exploring what are existing therapies. So we're screening existing drugs. For example, there's other rare disorders that have found potentially, like a blood pressure medicine has worked to help reduce seizures. So that's just a simple example of looking at existing drugs that could help. And we're also looking at various types of gene therapy. So there were several questions on, are FoxG1 kids good candidates for gene therapy? And yes, we believe so, and that's what we're investigating. We're looking at AAV9 gene therapy. We're looking at siRNA therapy. We're looking at RNAi therapy, at ASO therapy. These are all various types of gene therapies that are either going to increase protein level or decrease protein level. And the way that we're doing that is, if you take, for example, a mouse model, we're studying these mouse models, and the mice are based on real life patient mutations of FoxG1 children. We have looked at the gamut of different mutations. So Ellie covered, we have frame shift, nonsense, deletion, duplication, missense. We're looking at various mouse models. And if we could take an example of a mouse that we see, a mice may run by the age of 2 in a mouse year. I'm just giving an example, but we see that for a particular mutation, now the mouse is walking very slowly. So we see, okay, that's how FoxG1 has affected this mouse. We would then come in and give this mouse a gene therapy, and we would say, all right, in 3 to 6 months, does this mouse continue to walk slowly, or does it walk faster? Does it start running? And based on that, we have an idea that, okay, this gene therapy could work in this type of mutation. Then we would actually give that mouse line the gene therapy at different times, when the mouse is 3 months old, when it's 3 years old, when it's 20 years old in mouse years, and then see, okay, now does this mouse run faster, for example? At what age does it work? So that's just a simple example of the type of experiments that we're doing today. And the goal is, when we see success, to then go ahead and move it along, check that it's safe. Those are called toxicology studies, and then move on to actually a patient clinical trial in a real a patient subject. Ellie, do you want to add anything to that?
No, I think you covered it really well. I think the only thing I would emphasize is that we're trying to consider as many possible treatment avenues, just to make sure that to make sure that we have a strong candidate at the end of all of this, and not that we sort of sunk all of our eggs in one basket and it ends up not being effective. So we are trying to keep as open a mind as possible and to learn from other groups as much as we can.
Yes, exactly. And we have questions around, are there biotech companies that are already interested in FoxG1 syndrome? And the answer is very much yes. We spend a lot of time building relationships with biopharma across the world, with large companies like Novartis, all the way to very small companies like Ultragenyx that develops drugs for, as small as 10 patients. We're in talks with all of these companies. They know what we're doing. We send them updates. And the goal is to have one of them come, or multiple of them actually come and work on finding a cure for FoxG1 syndrome. If we go to the next slide, we'll see that we are working with a host of different scientists. We are extremely fortunate that Dr. Siu-Kyung Lee and Dr. Jay Lee, if you guys don't know them, they are fellow parents, FoxG1 parents, and they are also neuroscientists. They're located in the University of Buffalo, and they are the ones that are building our mouse models. And both Sue and Jay are really in the center of a lot of our FoxG1 work and are collaborating with the rest of the scientists on this slide. Dr. Alison Moitri, Flora Vaccarino, and Dr. Antonella Malamaki are all working on iPS lines in various different capacities. They are all collaborating with one another, trying different types of RNA technologies and characterizing these stem cells. And then Dr. Corinne Huart at King's College is working on our zebrafish lines and our modeling there and doing drug testing in zebrafish. We are also starting to work with Dr. Nadia Bahiboussan in France. Many of you know her already. She has been following FoxG1 children for many years. And these scientists, we have a scientific advisory board, as I mentioned, and when we have a scientist that wants to study something, we have a pretty rigorous way of evaluating that scientist. Many scientists, if you give them money, they'll do whatever they'll tell you whatever you want, and we've learned that the hard way, and we spend a lot of time vetting what different scientists are doing, making sure they're working together. And for any area that we want to focus on, we have multiple scientists around the world submit proposals. We also spend a lot of time speaking to other rare disease organizations, like the CDKL5 groups, the Rett groups, to understand which scientists have really helped them, which have become one of their core group scientists, and who is better. And that guides us in many ways as well. And if you're speaking with a scientist, you would like us to evaluate them, please let us know. It's really important that we work together, that we don't duplicate efforts. And that's something that we've spent a long time focusing on. So we are having our next scientific symposium. We had one last year, which was very successful during the neuroscience conference. This year, we have Sue and Jay are going to be hosting the scientific symposium in the University of Buffalo. This will happen in August. It is open to all parents and all scientists. We are just putting together the agenda, and we'll post things and send emails out to all of you. So stay tuned for that. And now, how you can help. Like I mentioned in the beginning, I am a parent like you with a child with FoxG1. We are all parents, and there's various ways we can help. We will find a cure faster if we all come together and work together. Number one is data. So this patient registry is a great example. All of you that have filled it out have helped us so greatly. And if you know other parents in your communities, in your areas that you speak to, please encourage them to fill the registry. Please help them if they're having trouble. It's very important. If we send you more surveys, please take the 10 minutes to complete them. All of this is critical. And when we go and we start talking to biotech companies and biopharma companies, they repeatedly ask us, how much data do you have on patients? How far is your patient registry? Are you thinking of doing observational studies? I mean, they will not look into a disease area unless they have very good understanding of the natural history of a patient. So that's a huge way that you guys can help. Fundraising is another, and we know that many of you are under pressure as it is. Life is very difficult, but even a simple Facebook fundraiser that could raise $100, if we think about if everyone on this call raised $100, we'd have $17,000, and that's a big chunk of a project. So any little thing you can do adds up. And then marketing, we are always looking for marketing help. Nicole, who many of you know, amazing parent, one of our co-founders, is doing an excellent job on marketing. She's the one who writes all our newsletters, puts all our presentations together, does all our social media. She's always looking for help, so please reach out if you'd like to do that. And then as Ellie, talked about earlier, looking into things like communication, AAC. We are constantly looking for parents who want to help us, who've had, if you've had really good experiences in AAC devices and you think you could put a guide together for parents, we would love to put that up on our website. We have a parent who is in the same city as me in Palo Alto, who is going to put together resources for parents, educational resources. That's excellent. More help that we can get in areas like that, we'd love to put on our website to help guide other parents. So just reach out if you'd like to help. And communication is really critical for us. We are transparent about every single thing we do. Our research projects, everything is on our website. You can always know what we're doing. Please make sure you're receiving our communications. We are on Facebook, we're on Instagram, as well as Twitter. So you can connect with us on any social platform. And if you're not getting our emails, Nicole's put a URL down there that you can click on, and you can get our newsletters. And on Facebook, there's a Get Our News link as well. And that's it. So I'm going to look for any other additional questions that have come in. We've got a question on Anavex. Anavex, I don't know if you know anything about that. Ellie, we've got a question from Jamie asking, can you use Anavex? And I'm not sure what these numbers mean after, but there's a 2 and a 7 and a 3 for Fox Kids.
I'm not sure what that is off the top of my head, but we can look into it.
Okay, we've got a question about the skin biopsy. That's a great question. If you go to our website, under For Parents, there's our biobank forms, and you could just simply add your information there. You will get a kit sent to you. You will get instructions for your doctor, for your pediatrician, anyone can do it. And then there's a shipping label, so everything is free. It can be sent back to our lab at Coriel. And we have gotten funding from the US government to host our biobank for free, which is amazing. So all of our blood samples and skin samples are hosted there. They in turn turn those into something we call fibroblasts. And those are accessible to any scientist and biotech company in the world that wants to study FoxG1 syndrome. So we're really, really happy and fortunate we have this global biobank. Let me see what else we have. How do you introduce? Okay, we got a question around gene therapy, which is a great question. How do we introduce gene therapy into the patient with an inactivated virus? Ellie, I'll let you answer this.
So it's a bit of a tricky question because we're not 100% sure what our approach will be yet. One thing that we know for FoxG1 is that the symptoms that we're seeing are mostly occurring because of the brain. And we know that FoxG1 works mostly in the brain. So in many cases, a gene therapy has been introduced either intrathecally, so with something like a lumbar puncture, or also maybe using a device that allows it to enter sort of the space of the brain directly. Those are questions that we're thinking about in tandem with what the actual agent will be, because those two things kind of go together. But I would say most importantly, we're trying to think about ways that are safe and can ensure that we're getting a good amount of agent where it needs to go, which is the brain.
Mm-hmm. I've got a last question here from Monica, and this is a great question, asking about surveys and information in Spanish. So right now, our registry is translated into 5 languages. That includes Spanish, French, Mandarin, English, and there's one more, German. So those are the 5 languages that are available, and now you simply go and there's a area you can go to change the language. So all of our surveys going forward will also be in these 5 languages. And in terms of information being in different languages, we hear you. We do have leads in different areas of the world helping to translate information, and we'll continue working on that. And one question that Christine has just added in is that the skin and blood for sending samples are free for everyone. It's not just in the United States. So they will send a kit to wherever you are located, whatever small island you're on in the world, they'll send you a kit and you could send it back for free. So thank you. This was our first webinar that we've done for parents. Thank you so many of you for joining. And this is truly a labor of love and passion. And thank you all for being on this journey with us and in our community. And we will find a way to help our children. We will host another Q&A soon, and we'll continue to do these webinars as we get more data. And we are about to launch and announce a very big and exciting research survey study that we'll be doing. So stay tuned for more information on that. Thank you, Ellie, for being on our team and for making FoxG1 your passion. We could not do any of this without you. And with that, goodbye and have a great rest of your evenings or days.